formal lecture and historically would have been given in person, but of course you know that that is not the situation that we can use at the moment. If you can kindly therefore keep your microphones muted so that we don't get breakthrough noise from your end while Sheona and I are doing the lecture, I would be very grateful. And really nice to see people on camera, but it's up to you if you want to switch the camera off for some reason as well as the mic, that's absolutely fine. We won't be taking questions live because again, in a formal lecture, we wouldn't have that kind of informal involvement, but Sheona and I will reflect at the end of her lecture on some of the discussions, and if I see anything burning in the chat, I will pick it up, or Sheona's already kindly said that we can, be contacted afterwards for people who want to develop some of the thinking around her talk. So we are recording the lecture, and that allows people who can't join us live tonight to watch it later. So that's another advantage. By attending the lecture, you're consenting to the recording, though you won't normally be visible or be named unless you actually speak for some reason, which, as I say, we're not expecting, but that's the basis of the recording. So I hope that's okay. And now, there are actually 3 named lectures that the college hosts by selection of the lecturers according to the category. The Pickles lecture, as many of you will already know, recalls with great respect one of our college's founder members and indeed our first president, William Pickles, who was a GP in Aysgarth in the Wensleydale area. And he's really known both for his excellence as a local GP and as a really innovative epidemiologist. His reputation lives on, and not just in the minds of older people like me, but I was delighted this week to have be contacted by colleagues from one of the medical schools in the Netherlands who are wanting to name a student prize after William Pickles in their context of students doing projects in general practice. And I just thought that was absolutely lovely that people of that generation are still hearing about William Pickles' work, including in other settings. The lecture was first given in 1968, and as well as it marking our respect for Pickles himself, it actually marks respect for the colleagues who give the lecture, because each year we choose somebody based on their work, their achievements, their contribution to general practice. Pickles is, this theme is particularly the educational lecture of the year. And that, of course, brings me to the great privilege of introducing this year's Pickles lecturer, who is Professor Sheona Macleod. Sheona is HEE, Health Education England's Deputy Medical Director. She leads on education reform. She's an honorary prof at the University of Nottingham and at Leicester. She actually graduated in Scotland before she moved to Derbyshire, where she worked as a GP for 26 years. She's had a number of special interests. She did occupational health work, clinical assistant in a community hospital, and as a medical officer in one of Her Majesty's prisons. But latterly in her career, she's been really committed as a leader in healthcare education. She was GP Dean, I think, in 2009, Postgraduate Dean 2012, Regional Director of Education 13-14, and then appointed as Deputy Medical Director in 2017. And most recently led HEE's extensive Future Doctor Review. And she chairs a number of national working groups and committees looking at how to accelerate improvements in education and training, including the HEE Assurance Group for Training Recovery after COVID. And I know that Sheona's taken some very serious experiences during the COVID pandemic. She was covering the interim medical director, so amazing work. And I'm very, very grateful to you, Sheona, for agreeing to give this lecture online for us. We started putting things off, but we really don't want to keep putting off these special, inspiring moments that give us some refreshment and remind us of the world outside the pandemic. So we're really very grateful to you for giving us this new opportunity, and we're really looking forward to hearing you speak. So, Sheona, your theme is The Future Doctor, Touching Hearts and Minds. Thank you. Over to you.
Thank you, Amanda. Now I'm looking to you for the thumbs up that you can actually hear me. Yes, as we had some interesting glitches trying to get the technology to work. So firstly, I need to say thank you for the honor of inviting me to speak. It is a real honor to be able to speak at William Pickles' lecture. It's an interesting challenge doing it virtually, and I hope I can make it as interesting for everyone as the lectures that I've heard in the past in the college. I'm aware I'm speaking at a difficult time when healthcare's...
Sheona, you just muted yourself by mistake.
I didn't touch anything. There is something very funny today.
Okay. So you said you're speaking at a difficult time was the last thing we heard.
I'm speaking at a difficult time. One is we have to use technology, which seems determined to throw hiccups in our direction. But it's full of contradictions, healthcare at the minute. We've seen both ends of professionalism. We've seen real heroism in the face of fear and exhaustion in our healthcare workers. And yet at the same time, we've had the shining of a light onto some persistent embedded inequalities in our healthcare systems. We've seen the really positive impact of mobilizing resource for intensive care in hospitals, and also seen the devastating results of neglecting simple care in the community. We're seeing the exhaustion of so many staff, and yet a widespread enthusiastic increase in applications for a healthcare career. The slides have moved. But I'm going to talk about the future. Doctors in the future, what attributes they will need to work in the health and care system we hope patients will have in the future, and how we should support the development of students and doctors in training for this future. I'm giving a personal view, but it's been shaped by the work we did in HEE, published in the Future Doctor Programme report last year. By my experience working with doctors in training over a number of years, by the COVID pandemic, and lastly, by my personal experience when I found myself facing a serious diagnosis and taking on the role of a patient in the last year. Now, the Future Doctor report was based on literature review, feedback from providers, patients and trainees that we collected in the regions, workshop that explored future needs through the lenses of different possible scenarios, a formal call for evidence, and national stakeholder events and focus group. And this gave us a future vision to inform our workforce thinking and planning for education and training. Much of what we heard was aligned to the trajectory of changes that we were already following. And it was emphasized by a lot of what we experienced and witnessed in the last 18 months. Now, there was a wealth of information that we got from the Future Doctor work. And I imagine you're now all thinking about technology and artificial intelligence and genomics, as they're all key elements of the future. But I'm going to focus on the human side of doctors, which is probably just as well as you've seen how able I am to work with technology. But it's also because that's what really matters to me. The relationship with patients, the relationship with others in the team, their confidence in managing complex comorbidity that we're going to increasingly see in healthcare, and doctors' desire to address health inequalities and support the health of populations as well as individual patients. I also want to consider how we'll support doctors to develop and what that means for the future of medical training. So firstly, we heard that most doctors value their personal relationships with patients more than any other element in medicine, which I think is a relief. This applies to GPs, those working in the swampy lowlands, as Sean described, working with the reality of complex problems which present as messy, indeterminate situations rather than well-formed groups of symptoms. I've always thought that describes my experience of general practice rather well. But it applies equally to those in academic uplands, leading research and looking to advance medicine globally. They understand the possible impact of their work on individuals through their personal interactions in clinics and in practice. It's these personal interactions that doctors value. They enable them to absorb innumerable details about patients and their care. This allows them to choose the best option for prevention, diagnosis, treatment, or support. It stimulates that questioning for research, and it shapes medicine. It enables the development of clinical expertise and that seemingly intuitive rapid diagnosis by experienced clinicians who can assimilate verbal and non-verbal information to produce a differential diagnosis with some of the analysis barely seeming to reach consciousness. The relationship allows the development of the key therapeutic tool, the doctor-patient relationship, which can be informed by technology, but it can't be replaced by it. During COVID, with social isolation and shielding, we all saw the vital importance of human relationships and human contact. It's also important for doctors, so they can express empathy and compassion through a human connection with their patients. Doctors feel a need to treat more than the disease that patients present with, despite the NHS systems that we have created. We all know the benefit of investing a little more time to see the whole picture, GPs more than most. The time spent in one long consultation or in many small ones over the years enable GPs to develop relationships and practice holistically, despite what, if you stop to think about it, are astonishing time limits on the time that you have with patients in a consultation. Yet our target-driven NHS culture belittles the need for time. We heard from patients how much they value the doctor-patient relationship. They like to describe it as the patient-doctor relationship, in enabling them to develop trust and ensuring they get the best care as individuals. But both patients and doctors said that this relationship's shifting and the future will need even more of the partnership approach advocated for years in general practice to enable the best personalized care across primary and secondary care. I was surprised how difficult it was to make informed choices about care when I became a patient. I'm not usually known for not knowing my mind. But one of the things I appreciated most was the time and support I was given to understand what different options and risks meant to me personally. We heard from junior doctors who can embrace advances in technology rather than struggle with them, that digital advances must not be used to change services in a way that erode the time for patient interactions, as that was what they valued about a medical career. New innovations must inform these interactions to improve them. And as Eric Topal said, release the time for care. Our patients have also increasing access to information and are now heavily influenced by social media, as medicine has to deal with increasing comorbidity and the challenges of social media. I suppose I need to say at the minute, can people go on mute? Because somebody's having what sounds like a nice dinner. But as our patients are influenced by social media and medicine has to deal with increasing comorbidity, and we move away from attempting to define a single diagnosis and treatment solution to finding the optimum mix of imperfect possibilities, patients will be increasingly informed and misinformed. And so they need a trusted interpreter who can help them find their optimum mix and balance the whole picture. The second theme that I wanted to focus on is team working. We heard repeatedly that a key element of the future is effective team working, and doctors need to be proficient at taking up all kinds of different roles within the team. Junior healthcare staff and students understand the need for team working, and we hear they're often initially bemused by the unspoken cultural rules that push our clinical practice into silos or create unhealthy tribalism. Industry has trained people in team working for years, especially where patient safety is important. We're now prioritizing this in health, so that being an effective team member is a key element of professional practice and a crucial skill for a doctor to develop. Modern general practice, where the skills of a number of professionals are brought together, is clearly ahead of the thinking. But we do all need to question what it is in our behavior that encourages and perpetuates the silos. Medical support is one of the strongest drivers for multi-professional working. By advocating a team approach, doctors empower other members of the team to do the same, and they enable the public to appreciate the benefits in seeing the most appropriate team member for the different aspects of their care. COVID created an environment that necessitated the removal of many traditional barriers and required more cross-sector team thinking. It demonstrated the power of effective distributed leadership across professional silos, shared decision-making and the involvement of all grades of staff gave clinicians a greater sense of shared purpose. And with flattened hierarchies and different professionals taking different leading roles, it boosted morale and the value of all team members was affirmed. Patient representatives told us how much they welcomed greater cross-team working. But they and their representatives saw the team in much broader terms, not just a multidisciplinary team, but teams extending beyond a single organization and across care settings involving the coordinated efforts of many agencies. So the doctor of the future will need to understand and value the roles and perspectives of many others if they're going to effectively create holistic care for an individual or patient group. Through my own experience of care, I was surprised how much I valued a multidisciplinary team. Other doctors asked me about my surgeon. Doctors do tend to think in terms of other doctors managing care. But actually, as a patient, knowing that others were involved was immensely reassuring. Not just the surgeon and her experienced surgical colleagues, but the pathologist, radiologist, oncologist, and the physio, and especially those wonderful specialist nurses, all providing their perspective on what was best for me felt really positive. You may be thinking prioritizing patient interactions and working well with others is a need for all health professionals. So what's particular to doctors? Well, one of the key current attributes of a doctor that's valued by patients, employers, other health and social care staff is the doctor's ability to understand complexity. Now, this is both the internal multi-system interactions of organs and systems and disease, but it's also the external complex health, social and environmental interactions. Now, the ability to hold the uncertainty that this creates and balance the risks to make the best decisions is what is valued by everyone. Doctors also help others understand and balance these risks so that patients and other healthcare staff can participate in that decision-making. Our lay representative group highlighted the value patients put on this and on doctors who help them make sense of the world when they're feeling vulnerable and confused. However, to understand the possible impact of interventions in patients with multi-morbidity and multi-external influences, our patient reps said they thought the doctor must have a broad general understanding as much of society as of disease. This isn't a new concept. Kessel said in 1960 that great reliance was placed on the GP's opinion, as this usually incorporated a knowledge of the patient extending over many years, together with experience of the family, but an awareness of social and economic difficulties. 60 years on, with the benefit of technology, we can significantly expand the breadth of understanding of the social and environmental determinants of an individual's health. This will be able to enhance individual doctor-patient discussions and really personalize care. I think most doctors are recognizing the need for all of us to enhance our skills as holistic generalists and create a universally greater understanding of the impact of comorbidity and the wider determinants of health. Even in the overwhelming single disease crisis we faced last year, a holistic approach was required to take the tough interventional decisions, considering what influence comorbidity had on personal and social health risk. And a holistic, broad approach will certainly be needed to manage the slow burn crisis that's been building for many other patients with diseases we haven't been able to manage appropriately in secondary care during the pandemic. I was lucky. My surgery wasn't delayed. But for others, the problems with their health and life will expand as they live through the uncertainty caused by delays in tests and treatments as a result of the pandemic. And it will take a much more holistic approach to restore the whole person to healthy living. Those of you who know Prof. Kundi will be well aware of how he has repeatedly shown that single disease morbidity is going to be an exception in the future. So if this is the case, across medicine, we have to have a change in our approach. We can no longer say that a generalist or a holistic view is only the expectation for general practitioners and perhaps those in public health. COVID shone a really bright light on inequalities. And Chris Whitty said recently, if you're not interested in health inequalities, you're not interested in health. So the doctor of the future needs to be aware of the health of society, to be able to advocate for all patients in the development of different care models. Fortunately, the younger generation of young doctors and medical students also see their responsibility as extending beyond the team looking after the patient to both the local population and society, and to the wider global environment. Many of the junior doctors and the medical students we spoke to actually judged a lack of attention to global issues, such as sustainability, as unprofessional. Focusing on the individual patient or patient pathway was not enough for them. The younger medical generations believe that doctors, as leaders with influence, should act to address health inequalities, resource management, carbon footprints, and use our possible influence on the wider determinants of health. They want to do this, and many of them were keen to be involved in social activism and accountability from early in medical school. COVID increased the understanding of the public about the immense importance of social factors such as isolation and some of the wider health risks associated with multimorbidity and disability and frailty. But our traditional ways of learning haven't focused sufficiently on the doctor's role in this. And young doctors now want training which allows them to have a much more positive impact on society, as well as on individuals in their care. This was echoed by the patients we spoke to. One patient rep summed it up in describing the doctor they wanted for the future, who would understand societal and genetic influences, take a holistic view of them as a patient, as a unique individual in their own specific environment. So what does this mean for doctors, especially those in training? Well, firstly, we need to make sure that doctors are well. Exhausted doctors do not have the resilience to provide holistic care. The patient reps we spoke to were clear that well-being is a patient safety issue, and it's essential for compassionate care. So we've known for some time that stress and tiredness affect patient care. And doctors in training all talk about well-being now. They've got a wisdom that I didn't have while I was training, and they recognize the pressures that exist. Along the whole career pathway, doctors are considering leaving or retiring in exhaustion. Yet COVID forced us to make adaptations to support staff and protect vulnerable healthcare workers. So it is possible to change. We must build on this and push the possibilities for greater flexibility in job plans from now on, and support our medical workforce to remain healthy throughout their medical careers. As we increase the pace of service recovery, we are setting the pattern for the future. And we have to look after doctors so they can deliver care, so they remain motivated, and so they stay and work in the future. We all know this, yet I suspect it will be much easier to say this than to make it happen. In wondering why we haven't addressed this when it's something we know, I wondered, is it we accept the level of stress in the NHS because the workforce still seems able to deliver results? I think you'll all be familiar with this concept that too little stress or arousal is demotivating or boring, and a certain amount is needed. But once you overdo it, performance decreases when you overload people. Personally, I think using stress and need together in a sentence is dangerous. But this work of Yerkes Dodson years ago that started this model is actually better represented by two graphs, although it's very seldom portrayed that way. They found that simple tasks can continue to be delivered as stress increases. but performance drops early for more complex tasks. Now, in the NHS, we're looking at increasingly complex comorbidity in the population. Yet as the pressure increases, the delivery of care is risking becoming even more falsely single outcome focused. If the future is multimorbidity, are we simply gaining false reassurance by simplifying our views of good care and measuring single outcomes because they're easy to measure? Meeting targets may not be the same as providing effective, complex, holistic healthcare. And GPs know this well. Neglecting the whole patient may risk a much greater societal cost in the longer term in terms of readmission, repeated attendances, or a social care expense, never mind the personal cost to individuals. So looking into the future, when the population is so much older and multimorbidity is the norm, the need for broader, generalist, holistic thinking to effectively manage every patient episode is clear. But is that message clear to those starting out on their medical careers? What do they hear from experts as they progress through education and training? We have to prepare all doctors of the future to learn and value the broader perspective, not just those thinking of general practice. And so I would really like to commend the work that all of the GPs in the college do, teaching that perspective to medical students and to junior trainees across all specialty training. So how do we help doctors develop a broader perspective? Well, one of the things is to enable doctors to take a more holistic view. We need to allow them to develop a broader perspective, perhaps in life and training, than that they usually gain in traditional specialty training pathways. Taking time out of training programs to access different opportunities in life or access different specialty experiences is not viewed as career enhancing in the way that taking time out for research or additional training within a specialist field is. But it might make you a much better, more rounded professional. Whatever else doctors are going to need in the future, they will need to be adaptable as advances in medicine change practice and as we deal with whatever new challenge like COVID the future brings. Medical careers are now much more likely to alter in a working lifetime. Fortunately, the future generation want flexibility and an ability to change. But training needs to recognize that from the start. And so we have to continue to expand the flexibility initiatives during training, which I can't help but plug all the work we've done in HE through our Enhancing Junior Doctors' Working Lives. In some smaller countries like Malta, doctors have to experience training elsewhere before they are actually given the equivalent of a CCT. We need to think about how our scoring systems in the UK value doctors' experience. Perhaps they could value those who could give more holistic generalist care because they have a broader expertise. Currently, recruitment scores value commitment to the specialty, and consultant panels look for highly specialist expertise. I think in general practice, you're wiser. Now, it's a well-known phrase that assessment drives learning, but actually it's equally clear that the hidden curriculum, the culture in the learning and working environment, and the presence of role models is as strong a force in creating behaviours. And we still overvalue specialist care in education and training. But actually that's just one element of an NHS culture where there are still significant inequality, diversity, and inclusion issues that we need to address. Trainees still report behaviours that make me deeply ashamed of our profession. We all need to work to address the issues within our UK medical culture. They're accepted because people are afraid to speak out. But I wonder if they're also expected as true expertise and medical professionalism are too simply defined. I think we need a more modern construct of a medical professional and true professionalism viewed through the lenses of addressing inequalities and patient need. Professionalism that embraces personal health and insight, an ability to take and advocate for a broad, holistic, multi-sector approach, as well as having specialist skills. And that isn't yet how we view professionalism. We should celebrate the role models who can take a holistic, generalist view and empower inclusive behaviours. Now, I personally chose GP because of role modelling, and it wasn't just by an inspirational GP, but also by his colleagues, the surgical and medical professors in Glasgow, who invited the professor of general practice to their grand rounds each week. And they listened to and acted on his wise advice. They were unusual in their wisdom, but their holistic approach led them on to become chief medical officers in England and in Scotland. During COVID, healthcare staff saw a different kind of leadership, with role modeling by clinicians sharing the leadership role within teams. Rapid decision-making and continuous improvements in the approach to COVID were enabled by different multi-professional groups working collaboratively to solve issues both locally and globally. At that time, it was accepted that you must consider well-being, both your own and that of the team. And a holistic understanding of the impact of comorbidity and risks was really valued. So we can look at professionalism differently. And it's too important to leave to learn by osmosis. It needs to be emphasized as a continuous learning key element. Fortunately, education provides a useful lens for viewing professionalism and poor behavior. Because if we accept that everyone is trying to do their best and that we are all learning throughout our careers, then let's perhaps reframe unprofessional behaviors to insufficient learning and a need for us to use constructive feedback to help those displaying these behaviors to learn. We all have a concept of professionalism and ideas of what that means in terms of accepted behaviors. But only by talking about professionalism openly and honestly and being prepared to call out and address unprofessional behaviors can we change the culture in the NHS to enable more respectful and effective team working and to start to value other and much broader perspectives. And what of assessment? If we need a healthier, more generalist, holistic approach, should future assessment explore personal awareness and resilience, flexibility in thinking, and the ability and willingness to take a broader overview? I can see you all designing things already. But I would suggest, rather than exploring the assessment methodology for this, we just get out of the way and enable the doctors of the future to take the professional approach that they themselves are advocating, and that we support them in undertaking personal assessments of a holistic development need and their possible impact on society, and let that shape their career pathways. The pendulum's perhaps swung too far in trying to ensure our patients are safe through a huge assessment burden for both doctors learning and for those teaching. Now, we do need to assess learning outcomes, as we know that those with poor performance often have poor insight. But we hear an awful lot of the burden of this assessment. And we've actually seen in many specialties through COVID and in the changes in GP recruitment in recent years, that less can often be just as good as more. We need to allow doctors to have the experiences out of traditional programs and accept that this will give them a holistic approach. And we need to do this without the need for assessment and a certificate when they come back, and only in exceptionally asking for assurance of an additional competency. Employers and trusts and practices need to accept the value of learning from different experiences without a certificate to prove it. And only doctors can push that acceptance. When we consider the cost of training doctors, surely retaining their enthusiasm, broadening their experience, and letting them follow their interests is only sensible resource management, especially when their interests are in line with society's needs. In the shortest of the specialty training programs, general practice, I realized that advocating this approach will undoubtedly increase the work of those overseeing the complex program management of the training journey. But as those who understand a holistic approach better than anyone else, who already see the value in a broad experience in team working, I would ask GPs to lead the way in empowering our future doctors to have more flexibility and have an impact on society. So what will it be like working in the future? The contradictions will remain. More young people than ever want to be doctors, even though they've just seen how hard it is. We're facing years of continuous pressure and cost constraints. So it'll be a time where innovation and enthusiasm are needed, and bright ideas might be accepted more easily. And despite the pressures, there is still lots of enthusiasm. It's why teaching is so rewarding. So let us make the future a time of hope and greater wisdom. Hope for a healthier workforce with a more balanced working life. Hope for a greater understanding of what it means to be professional, with more inclusivity and a greater respect for others. Hope for a more flexible, holistic, generalist approach across medicine to allow everyone to embrace the inevitable complex health UK problems of age and comorbidity that we will be facing, and to work to address the inequalities in our world. Let's aim for shared wisdom as we explore what it means to act responsibly and be a professional in our changing world. Not just the wisdom of experts, but also the wisdom of youth, if we're just prepared to acknowledge and listen to it. And for education and training, it means change in supporting the development of the future professional in taking away some of the barriers, giving them more flexibility and autonomy in how they train and what they learn. Focusing more on learning about team working and being a professional, and creating learning environments that help them to develop and value the inclusive, holistic perspective, and encouraging them to follow their aspirations to address societal problems. We all need to reconsider professionalism our professionalism, and accept our responsibility for both being and shaping the doctors of the future. But it takes humility and humanity to do that. But when doctors take their humanity to work and look holistically at patients, then they truly connect with them, hearts and minds. Thank you, Amanda.
Thank you, Sheona. That was really wonderful, really moving and inspiring. Thank you so much. I don't know really what to say other than thank you again. On the one hand, there's the bit of me that's sort of thinking, gosh, what a great challenge to us. And knowing that people are tired and we have, you know, sort of 10 minutes, blah, 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 we can see the barriers that need to be overcome. In another way, what I took was, you know, that energy that I sometimes get when I have a good consultation with a patient or a trainee or a colleague, and sort of come out feeling inspired, even though we've worked really hard and it's been a really complicated task. And I think that if we can give ourselves the headspace and the opportunity to treat things as an opportunity for development and reflection and learning and be more flexible, that word is great, then I just think that would really help us through the dark times. I said beforehand that we wouldn't have a lot of time for, well, we wouldn't take questions. I don't know if you can see the chat, but I'm getting lots of people saying that was brilliant, that was brilliant, that was brilliant. And at the end, I shall try and unmute everybody, John, please, and we'll do a clap. But just if I've got one thing I wanted to ask you, it's, you were brave enough to share that you've personally had to be a patient recently, which gave you that additional insight. If there's one thing that you would say to us tomorrow with our students or our registrars or our colleagues that we can do to make sure that our patients get the best out of us, what would it be?
I think that's easy, Amanda. You just connect with them as a human. That's what being a patient, the humanity of different people, from the hospital porter to the consultants, being able to take your humanity there, that touch, that personal empathy, it makes the biggest difference to patients. And the reason I feel happy saying that is because I think that's what made every one of us want to go into medicine. And it's what we mustn't lose.
Absolutely. Fabulous. John, can we unmute? I don't know if we can. 62 people want to clap. Let's give it a go.
If everyone can unmute.
You can unmute yourselves, guys, or just show her on the screen. That's wonderful. Thank you. And now we have to mute again, otherwise we can't see Sheona anymore. There she is. So just so people know, the norm is that the Pickles lecturers will publish their lecture in our journal. So we look forward to that. As I said at the beginning, the opportunity to have recorded the lecture means hopefully members can watch it again, and people who couldn't join us tonight will also get the opportunity. So that really adds value. We're going to actually have, for our pre-council workshop, because we have college council tomorrow, we're going to go on talking about GP educators and how we can support them and value them. And I think any of them who've been on the call now will really be coming into that workshop very inspired. So thank you again. And I'm hoping, Sheona, that if we can go live at the AGM later in the year, we'll be able to present you with your award, because normally at this point I'd be giving you your certificate and a medal. But anyway, the thought is there, and the handshaking and hugging is also there. For colleagues, this treat is only the start of 3. We actually have 2 more eponymous lectures being given later in the year, one at conference, the John Hunt lecture, which will be given by Professor Michael Kidd, who I will post the background and the work that he's done, which is very much global health education, including a lot of research on the original AIDS pandemic, which has some modern resonances. Interesting. And then in November, God willing, it'll be the Mackenzie lecture, and that will be from Maureen Baker, who many of you will know. She held office in the college as chair and as honorary secretary. So we've got some more good times coming up. But at this point, I'm just going to thank Sheona again very much. I'm going to thank all of you for attending. And as I said, if you want to pick up any themes with us on email afterwards, or hopefully more in your own communities and rolling out the ideas that Sheona shared with us, that's a great opportunity. Thank you again, Sheona.